Hi, my name is Jen Fariello-Moldwin. I'm a nurse practitioner at the Smith Institute for Urology, Pelvic Pain Treatment Center. I've been treating women with chronic pelvic pain, vulvodynia, pelvic floor dysfunction, vulvar dermatoses for the past 17 years. I'm also a medical cannabis patient certifier in New York State for the past 2 to 3 years. So today I'm going to talk to you a little bit about the use of medical cannabis for chronic pelvic pain or other types of chronic pain. So first, let's talk about the history of medical cannabis. It has been used for the past 8 to 10,000 years medicinally. I'm going to go over a little bit of the timeline. So we first see it in writing in about 2700 BCE. Shen Nung, who's the father of Chinese medicine, first wrote about it in the world's oldest pharmacopoeia. He wrote about something called ma, which is a drink made of cannabis flowers in hot water. And he wrote about its healing properties for all types of different ailments and digestive ailments. Jump ahead a little bit to 1200 BCE, we go to Egypt and the Ebers Papyrus. That's where we first see the use of cannabis mentioned in gynecological conditions. It was ground into honey and put into vaginas to help ease menstrual cramps. 1000 BCE, in India, we see it used as an anesthetic. 79 CE, Pliny the Elder, he first mentioned the use for pain, for all types of different pain, joint pain, gout, so all types of arthritic pains. The end of the 1830s, William O'Shaughnessy brought cannabis to the UK. Dr. John Russell Reynolds, the Queen Victoria's private physician, used cannabis to treat the Queen's menstrual cramps. He put it in a tincture and gave it to her every month. In 1850, cannabis was added to the US Pharmacopoeia. That's the book of all the different drugs that we use in the US for all different types of medical conditions. And in 1850, cannabis was added to that. 1889, The Lancet, which is a big medical journal, first described the cannabis use for opium withdrawal. In the 1930s, all the pharmaceutical companies in the US sold cannabis as medicine. However, end of the 1930s in 1937, the federal government in the United States made cannabis illegal by passing what is known as the Marijuana Tax Act. Just so you know, this was opposed by the American Medical Association. 1941, cannabis was removed from the pharmacopoeia. 1970, cannabis was classified as a Schedule I substance, which means, so in the United States, we have 5 different schedules of all medicines that are FDA approved. Schedule I, anything that's listed on there, no medical value and a high risk of abuse. So just so you know, some substances that are on Schedule I: heroin, peyote, LSD, meth, and acid, and marijuana or cannabis. 1972, the Nixon-appointed Schaefer Commission recommended the decriminalization of cannabis. 1988, Judge Francis Young recommended that medical use of cannabis should be allowed and it should be reclassified as a prescription drug. Alas, this was the war on drugs in the Reagan era, and that was not put through. So it took until 1996 that California became the first state to legalize medical cannabis. And then on December 20th, 2018, Trump signed the Farm Bill, which made CBD products derived from industrial hemp federally legal. And now, 2020, 33 states in the United States are medical cannabis is legal, and in DC, and in 11 states and in DC, recreational cannabis is legal. And this is just a map of the US, and it shows where recreational and medical cannabis are legal. So this is just some fun stuff. Rob and I were speaking at an IC conference over in Amsterdam, and we went to the Marijuana and Hemp Museum. So this is just some fun stuff that they actually have there. So in the lower left-hand corner, that's actually a prescription that's written for a tincture of cannabis from an OBGYN from 1928. The top left corner, that's an order for opium and cannabis. And as you can see, an advertisement for kidney, liver, and urinary disorders for some cannabis tinctures and some real bottles for cures of rheumatism and stuff like that. So just very quickly, I'm just gonna go over the endocannabinoid system. This alone can take 4 hours, a lecture on this. This is very, very, very quick. Endocannabinoid system is an extremely complex system that we are just starting to discover. Endocannabinoids, the two main ones that I want to talk about today are CBD and THC. Endocannabinoid receptors, the two main ones, CB1 and CB2 receptors. There are many more. There are many more endocannabinoids. There are many more endocannabinoid receptors. These are just the main ones that we're going to focus on today. So endocannabinoids and their receptors interact like a lock and key mechanism. However, this system is much more intricate than other receptor systems. So if we think about CB1 receptors, this is a binding site for CBD and THC. This is an example of how CBD modulates the effects of THC. So for example, when you have low CBD, THC occupies that binding site. However, if you have a compound with higher CBD, that will land first on the receptor, making THC binding more difficult. So this is why you can have different strains of cannabis with the same levels of THC, which then produce different medical results. Medical cannabis has both CBD and THC. So this is not just CBD, this is the combination. And when you have both, it produces what's called an entourage effect. So the two of them together potentiate the positive effects of each one. So let's take pain relief. So when you have CBD and THC, you'll get that entourage effect. You'll get pronounced or more pain relief while you decrease the adverse effects such as short-term memory loss, panic, and anxiety that you can sometimes get from just too high of THC. So whereas some people describe it like a lock and key, you should really kind of try to think of it, the medical cannabis, think of THC and CBD interacting like an old married couple. So when I say that, I mean, if you think of them binding at the receptor site, they're going to the receptor site, think of them fighting with each other to try to get to the receptor site because they each want to get there. However, in the end, they really get along best when they're together. So if you just have CBD, it doesn't really work as well without the THC. So that's why a lot of people say, I've tried CBD, it doesn't do anything. You know, I've been on it, I don't really like it, I don't want to use cannabis. But they haven't tried it with the THC because it really does work a little bit better when you take them together. So here are all the cannabinoid receptors where they're expressed in the human body. This is really the CB1 and CB2 receptors. They're all over. So medical cannabis, it's used to treat approximately 105 plus conditions according to the International Society of Cannabis Clinicians. Our knowledge of this system is still evolving. We learn more and more about this all the time. Worldwide prohibition on cannabis has limited our medical research. We are just starting to do real good research on this. Dosing and outcomes are not standardized because we haven't been able to study it because it's a Schedule I. It is still federally illegal. However, thousands of clinicians and patients have accumulated knowledge of cannabis medicine. So we are learning anecdotally. We are learning from each other. We're learning from patients. They come back to us. They tell us their experience. We get together with other clinicians and we learn just by talking and by sharing our knowledge. But there's a steep learning curve. So we are still learning from each other too. So just the American Nurses Association says cannabis has been used medically for centuries. It has been shown to be effective in treating a wide range of symptoms and conditions. Chronic pain. In the US, over 100 million adults are treated for chronic pain annually to the cost of upwards of $635 billion. Current treatments, which I'm sure a lot of you have tried, either are on now, tried and failed, NSAIDs, antidepressants, muscle relaxants, neuroepileptics, that includes Lyrica, gabapentin, opioids, physical therapy, interventional procedures such as trigger point injections and nerve blocks. And this doesn't include all the alternative and complementary therapies that are listed. Pain is the most common condition which people use medical cannabis for, such as musculoskeletal pain, neuropathic pain, that's nerve pain, visceral pain, that's organ pain, so bladder pain, bowel pain. So with cannabis, there's no risk of overdose or sudden death. Even more remarkable, cannabis treats pain in a way opioids can't. Though both drugs target receptors that interfere with pain signals to the brain, cannabis does something more. It targets another receptor that decreases inflammation, and that's Sanjay Gupta, who I'm sure a lot of you know who he is on CNN, who was very anti-medical cannabis. And then I don't know if you know the story, he met this little girl who had Dravet syndrome, who is, which is a form of epilepsy where you can have upwards of 100 seizures a day, who the only thing that stopped it was a high CBD, low THC cannabis. And he totally changed his way of thinking on medical cannabis. And now he's very pro-medical cannabis for certain conditions. So chronic pain. So just a history of medical cannabis or cannabis and chronic pain. So in the 9th century in Persia, the juice from cannabis flowers packed into the nose of migraine sufferers to treat their headaches. Luckily, we don't do that anymore. We have different ways to treat it, to treat migraines with medical cannabis. It was used during the Civil War, which seemed to decrease the dose of opioid medicines to treat severe pain, which we are seeing today, that the use of medical cannabis is lowering the dose of opioids that people use. And in 1887, Hobart Hare, who was a professor at Jefferson Medical College in Philly, produced a really long article about the advantages of cannabis over opium for treating pain. So jump ahead to today, in like 2015, and Lynch and Campbell looked at 80 studies. And when a lot of these meta-analysis, and meta-analysis means that they look at all the studies and they say, so is this a good thing to do or is this not a good thing to do? And sometimes it comes out saying medical cannabis hasn't shown any efficacy for chronic pain or migraines. So they looked at 80 studies on chronic pain. And when they looked at these, they said, you know what, only 18 are really good studies. The rest are really not good studies. And out of those 18, 15 showed significant analgesic effect of medical cannabis. So 15 showed that it works. So that's, pretty good after you got rid of the kind of garbage studies. Agarwal looked at 38 randomized controlled trials published before 2012 and showed that 71% demonstrated statistically significant pain relieving effects of medical cannabis. It also showed that the results on chronic pain are very encouraging. However, the results on acute pain are not as successful. And we are seeing that. So when people give medical cannabis for post-op pain, it doesn't really work as well as when you use it for chronic pain. And one of the theories is that when you have these endocannabinoid receptors, you need to take the medical cannabis every day to saturate those endocannabinoid receptors, and then it works better. So Wallace and Furnish also looked at chronic pain and dosing and how much should you take to help your chronic pain. But they found out more is not always better. The low doses of cannabis didn't provide much relief. High doses of cannabis actually increased pain levels. It caused what's known as a hyperalgesia, or it made the pain receptors overstimulate. Moderate doses provided really good relief. So you have to kind of find that sweet spot right in the middle. When we counsel patients, we usually say, start low and increase really slow, just to find that spot because it's very individualized. So you have to find that level where it really kind of helps your pain. So for chronic pelvic pain, how did we start using medical cannabis for chronic pelvic pain? There was a study, Cannabis and Multiple Sclerosis, that looked at cannabis for spasticity. However, the patients had to keep a bladder diary. And at the end, they found that when they took the cannabis, not the placebo, that their urge incontinence and decreased and their bladder control increased. So researchers wanted to find out more about the receptors in their bladder. So they looked at animal models and cadaver models. And what they found out were CB1 and CB2 receptors were in the urothelium, or the lining of the bladder, and the detrusor muscle of the bladder, but they were 2 times higher in the lining of the bladder. Oh, so what if we target these CB1 and CB2 receptors in IC-affected bladders? So Tyagi and Chancellor put something called agilemic acid, which is a selective CB1 and CB2 agonist, in liposomes because it's lipophilic, or it's not water soluble, and put it into female rat bladders for 30 minutes. Then they put something called acetic acid into the bladder. That's to simulate a IC bladder, to make it irritated. And they found that local activation of the bladder cannabinoid system by intravesical or bladder administration can decrease pain signals emerging from the bladder. So activation of the CB1 receptors suppresses the hyperalgesia, and activation of the CB2 receptors suppresses the inflammatory mediators, which provides an analgesic effect for inflammation and neuropathic pain. So the Interstitial Cystitis Network, another patient support group network, did an online survey of its members regarding medical cannabis use in IC patients. So 118 patients responded. 67.5% used medical cannabis within the previous 6 months. 18.2 had a complete resolution of their symptoms. 63.6 had 50% reduction. 14.8 had a 25% reduction. 2 had none, and 1 said that they had a worsening in other domains that they answered questions on. So as far as pain goes, 31.8 had a complete resolution of pain. 55.7 had a 50% reduction of pain. Pelvic floor muscle spasms and tension. 31.3 had a complete resolution of their spasms and tension. 43.4 had 50% reduction, 12 had nothing. However, several patients reported decreased pain with sexual activity due to their decreased pelvic floor muscle spasms and tension. Half of the respondents reported 50% improvement in frequency, and half reported an 50% improvement in urgency. More than 3/4 reported substantially improved sleep quality, and more than 3/4 reported how many times they get up at night decreased to nothing to at the most 2 times. And finally, flares and flare management. 11% of respondents stated that medical cannabis use triggered their flares. However, when you read their responses, it's because it caused them to eat more food, they said, which they wouldn't normally eat, which they think caused their flares. 89% stated that it did not trigger their flares, or that it stopped their flares before it got too bad. Some other people that looked at medical cannabis and chronic pelvic pain, there was a retrospective study done of 35 women with chronic pelvic pain who used medical cannabis. 82 of those respondents documented a change in pain, of which 79 said that they had improvement. 3 reported none. Nobody had worsening of their pain. And of those 79 who had improvement, 39 reduced their opioid use. Only 9 people had side effects, and headache was the most common. Sinclair, and this is out of Australia, conducted a survey of women who self-manage their endometriosis. 484 women responded, 13% used cannabis. 7.6 out of 10 reported efficacy in pain reduction. 56% were able to decrease their pain medicine by at least half. They reported improvement in sleep, nausea and vomiting, and they reported side effects were very minor and infrequent. Reinert surveyed 364 female patients with endometriosis and or chronic pelvic pain who reported using cannabis or just plain CBD. Use of both, they found, is very common, and both were reported to be very or moderately effective for chronic pelvic pain, with cannabis reported as more effective than just CBD. So other benefits of medical cannabis, in addition to helping chronic pelvic pain, patients also report improved sleep, decreased anxiety, and improvement in other chronic conditions such as inflammatory bowel disease, irritable bowel syndrome, migraines, fibro, autoimmune disorders, in addition to other chronic conditions. Quickly, just a word on topicals. There has been some interesting developments on topical cannabis for dermatological conditions recently. It could have some implications in the treatment of neuropathic pain, such as post-herpetic neuralgia, chronic itching, such as eczema, lichen simplex chronicus, and conditions that cause scarring, such as lichen sclerosus. There have not been any studies for any type of vulvar dermatological conditions or neuropathically mediated vestibulodynia. However, that doesn't mean down the line we won't be able to use them. As anyone who has any of these conditions know, we use a lot of things, most things off label. My hope is that hopefully we'll be able to use these sooner rather than later. However, right now, I just implore you, don't use anything over the counter on your vulva without first checking with your clinician. The things you can buy at the store or at your local, vape shop or wherever, even at CVS, or they all sell now CBD products, have a lot of other ingredients that are not vulvar friendly, or even some men use it for scrotal burning or penile burning. They put some CBD. It can cause contact derm very quickly. I've treated a lot of patients that tried to use CBD on their vulva and they've come in with a horrible contact dermatitis. So don't use anything without first checking with your clinician. So can you get a medical cannabis card? First thing you do is you check with your state medical cannabis laws. If you don't know what they are, you can Google it. There's a website, leafy.com. You can go on that. It lists every state with all the conditions that are qualifying conditions. So then you check, do you have a qualifying condition? IC is a qualifying condition in Illinois, Connecticut, and North Dakota. However, chronic pain is muscle spasms. They are qualifying conditions in almost every state. Vulvodynia and vulvar burning was added to qualifying conditions in Connecticut in June of 2019. There are some contraindications to using medical cannabis. Pregnant nursing mothers, under the age of 25, certain cardiac conditions, usually unstable cardiac conditions, a history of psychosis or schizophrenia, and there are some interactions with certain medications. Again, check with your clinician. So what is the role of the clinician? So what can they do? When this first started, when we first started getting into this, there were all these questions. Is that legal? Is this legal? Can I say that to a patient? Because this is technically still an illegal substance. It's still Schedule I. So federally, it is still illegal. So what we can do, yes, clinicians can fully discuss risk and benefits of medical cannabis with patients. Yes, we can recommend, we can approve, we can endorse, we can suggest. We can use our medical judgment and tell patients that we think you would do better. We think you would do really well with medical cannabis. We can write it in the chart. We can sign government forms. We can sign forms saying that we recommended medical cannabis. We can testify in court. And if you have a clinician that says, I know nothing about this, I can't give you any recommendation, they can educate themselves on the benefits of medical cannabis, different applications. They can say, I don't know about this, but I can recommend you go to see XYZ to go get more information or to go get a medical cannabis card. They can definitely give you some guidance. What we cannot do, we cannot prescribe medical cannabis. This includes writing it on a prescription form and handing it to a patient. It is illegal. It is a Schedule I drug. So we do not prescribe medical cannabis. We can certify you to get medical cannabis and you can go to a dispensary and buy it. We cannot hand you medical cannabis. We cannot take you to a dispensary. We cannot have it in our office and give it to you. And we can't recommend it to you if you do not have a qualifying condition. So in summary, medical cannabis has been used throughout history for various medical conditions. It was used for medical purposes in the US until 1937, when it was then made illegal. So it was used for 90 years before it was then deemed to be illegal. It was classified as a Schedule I drug in 1970, and it remains that way. Today, 33 states and DC recognize the medical benefits of cannabis and have legalized its medical use at the state level. It is still extremely difficult to do placebo-controlled randomized trials because it is still a Schedule I drug. Don't be afraid to speak with your clinician about medical cannabis. If they do not certify patients, they should be able to refer you to someone who does. Remember, more is not always better. Start low and go slow with cannabis. Moderate doses have been shown to provide the best pain relief. Thank you.